Our next topic is fever with rash, an approach towards diagnosis by none other than Dr. Sandipan Dhar, sir.
Whenever I have spoken on this topic to my pediatrician colleagues in the different IAP programs, I think at least 10 to 12 times over last 20 years, I have seen that many of my pediatrician colleagues trying to pull our legs, saying that it is the rash which brings cash to the dermatologist. So I started thinking that how to make an idiom to give a good reply to them. So I have made an idiom this time, just 5 days ago. It is the fever in a child which sends shiver across the spines of the pediatrician. So friends, let us come together without fighting, because this needs a joint venture, because this is one of the most challenging area of medical science, clinical medicine, I must say. When a febrile child comes with skin rash, whether it is a pediatrician, a dermatologist, or an internist, adult, child, so for everybody, it becomes a big headache how to reach out to the proper diagnosis. So there are maybe different types of presentations morphologically. We, the dermatologist, always go by morphology. And then only we make the diagnosis. The list is very exhaustive. However, today I shall discuss something which are relevant, which are common in our practice as well as your practice. And for your knowledge, something which has to be kept in mind, that these are the newer entities. You should be aware about these. Rest of the things, I am sure Dr. Shomo Panda has, prepared an exhaustive questions to tear us apart, all the panelists. He is, evidence-based medicine person. And let me tell you, he is the only person in Cochrane's evidence-based medicine from India. It's a matter of big pride for us. I am not telling all these things so that he doesn't ask me questions. So measles. Measles, we all know that how the rash presents, and when subsequently the rash subsides. But something which is very interesting, and you have been reading it from your MBBS days, Koplik spots. What is the mystery of Koplik spots? So this is how the Koplik spots look like. It is against the first molar tooth. It appears by and large on the 4th day, but it disappears within 7 days. Sometimes it may be extensive. I hope you have seen it. Most important differentiating point from measles is the drug rash, and that is the mute question asked to us by every pediatrician. That is the question asked by the parents. The doctor, invariably the parents will incriminate everything to the drug taken. The other day somebody was telling that he has been given tofacitinib, and he was saying that I am not having sleep. I could not find any literature that tofacitinib causes lack of sleep. Even somebody took a vitamin B complex, told I am feeling very sleepy throughout the day. Right? So patients will incriminate everything. The doctor, you have given the drug, and because of that it has happened. And that invariably happens in such scenario. When a febrile child develops rash, they incriminate the general physicians and the pediatrician. The pediatrician gave this drug, and because of that the rash has come. Then we take time that, look, this has nothing to do with the drug. This is a sequence which is following. Let us look at some of the pertinent differentiating points between measles and the drug rash. This is known to mostly all of you. Constitutional symptoms is less in case of drug rash, which is more in exanthem. It is abrupt in onset in drug rash. It follows a sequence of events in viral exanthem. Pruritus is present in drug reaction. Pruritus is absent in viral exanthem. By and large, there is a little bit of burning or stinging sensation. So the look of the rash, involvement of the sites, and the systemic involvements are the other points. So coming to another disease, common disease known as fifth disease or erythema infectiosum, where the classical thing is sometimes you feel like doing the other person slap cheek appearance, right? So this type of erythema is called, slap cheek appearance. This is a parvovirus B19 infection, and in different stages it spreads to other parts of the body. I shall be quickly going through because I have to follow the Gotiman express schedule of my brother, come big professor, Professor Manjunath Senai, right? So because this topic is very exhaustive, and we have already taken a little bit more time, so I am looking at the time also. So this is Kawasaki's disease. I think there is no difficulty in making a diagnosis. It has got a criteria I shall show you in the next slide. But this type of erythematous leaf exfoliation, inguinal erythema, perianal exfoliation is something very important. In a girl, perivaginal exfoliation is again very, very important. Apart from fingertip exfoliation and other things, we know rest of the other features. Let us have a look. This fingertip exfoliation, as I mentioned, this is not my patient. This is taken from the textbook or journal. So all these criteria are known to us: unilateral, non-suppurative, lymphadenopathy, blah, blah, blah. Plus, please do remember one thing. By a person who has done maximum work on Kawasaki's disease is none other than Professor Surjit Singh from PGI Chandigarh, who is considered as Indian Kawasaki. So he says that Kawasaki's disease is older, presents at an older age in Indian children. And he is the person who got Shimizu Kawasaki to Advanced Pediatric Center from PGI Chandigarh. I have got a very good relation with him. Excellent relation. So dengue fever is basically a flavivirus infection. There are 4 types of flavivirus, right? As you all know, it presents with hemorrhagic lesions. That's why it is called dengue hemorrhagic fever. You can have subconjunctival hemorrhage. Lots and lots of things but something to remember is one single important, clinical feature of dengue. That is this island of normal looking skin within the red ocean. And what is the significance of it? First significance, that it is almost a monopoly of dengue fever. It is not seen in any other condition. That is number one. However, it is seen only in up to maximum 50% of the cases of dengue fever. Second thing, if you see it, you can confidently tell the pediatrician, the dermatologist colleagues I am telling, pediatricians and pediatrician colleagues, you take it as a note that your child's platelet count is going to recover from tomorrow. I have done it 100 times and I have not failed on a single occasion, because this type of rash develops during the second stage or recovery phase of dengue fever. So immediately the parents you will become God. Somebody may ask you, doctor, where is your astrology center? Right? So this is the type of rash. Next to my clinic is actually an astrology center. So many of the patients, they by mistake, instead of coming to me, they go to that center. I say, go, good, you go there. They will tell you your future of the disease. I won't be able to tell you. Hand, foot and mouth disease. This is the type of presentation. Many a times it is confused with, varicella or chicken pox. Please do remember that chicken pox is polymorphous. I shall talk a bit more about that. Earlier also it has been talked about. And here it is, all are monomorphous lesion. Second thing, a hand, foot and mouth disease child will come in your clinic and the child is running around playing. Only the mother is, super excited and tense. Okay? Chicken pox child doesn't never behave like that. It's always very sick, toxic, high fever. Here there is hardly any fever, if at all little bit, mild fever. So immediately you can make a diagnosis that this is not chicken pox, this is hand, foot and mouth disease. Look inside the mouth. If you have any difficulty, look the 2-3 sides. These are the sanctuary sides. One is elbow, one is knee, One is, of course, the palms, and one is the body folds, elbow fold, gluteal fold. These are very common areas. This is another area, knee. Such clustering of vesicles without underlying erythema is very classical of hand, foot and mouth disease. In chickenpox it is, in herpes, because both of them are related virus, there is underlying erythema. And lack of toxicities. Fever, at all, if at all, very mild. Please don't do one thing. Like earlier you have said, don't give topical steroid with antifungal. Don't give acyclovir. Acyclovir has got no role in the treatment of hand, foot and mouth disease. Right? Close up of the lesions. Coming to another very tricky disease, rickettsial disease. Nowadays we have been diagnosing a lot in our institute. So much so that our residents will come with a file, big file and a child while I am in the OPD. Sir, please see whether this is Rocky Mountain spotted fever. Sir, see whether this is, scrub typhus. So every case they suspect like that. And I don't discourage them. Because for diagnosing this disease, high degree of suspicion is needed. What the mind does not know, eyes cannot see. So at times overdiagnosis is not bad, particularly for such disease. For Kawasaki's disease, if you think a child has Kawasaki's disease, Dr. Surjit Singh says every child, in his department, I recently visited PGI Chandigarh, I went to his department, in his department, every child having fever with this criteria undergo the echocardiography to save the life of the child. So here also this is a condition where you can save by giving doxycycline. Nothing is going to happen with doxycycline. It has got no side effect. So rickettsial disease presents like that, as you must have read by this time. You can say, how can I do two things together, listening to you at the same time reading? I am sure that you have done both the things together. So doxycycline can be given. That is one very important thing. And these are the states where rickettsial disease has gradually increased over the period of time, right? And there are types which have been identified in Indian scenario like scrub typhus, spotted fever, Indian tick typhus, rickettsial pox. This is scrub typhus, not our patient, from book, as you can see it. This is the typical Indian tick typhus. This is also, not my patient. So, or any of our patient. This is also from book. This is a cigarette paper like scar. Now rickettsial pox. How to differentiate rickettsial pox from chicken pox? See, this is rickettsial pox. All lesions are monomorphous, vesicular lesions. This is chicken pox, right? So here you can see macular, papular, vesicular lesions. This is not our patient. This is from book actually, right? This is our patient, my own patient. So you can differentiate. One is polymorphous, rickettsial pox is monomorphous lesion. Now coming to some case scenarios. A 7-year-old girl presented with high fever, arthalgia, skin rash of 2 weeks duration, and you get to see such lesions, right? So these are hemorrhagic lesions which are very characteristic of rickettsial disease. And unless and until you suspect this disease, immediately put the child on doxycycline. Probably you may lose this child. Please do remember this. We have seen many such children who died in ICH earlier days when we didn't have awareness about this disease. Now no child dies of rickettsial disease in ICH because we overdiagnose it, frankly speaking. And there is no harm in such conditions to overdiagnose. These are the cases which have very kindly been given to me by Dr. Arun C. Namdar, my good friend, and a very brilliant pediatric dermatologist from Karnataka. You see, these are the hemorrhagic lesions. Large hemorrhagic lesions in rickettsial disease. See the swelling of the forearm that suggests edema. Coming to another case scenario, a neonate of 21 days presents with biliary pigmentation over the face and limbs since birth. Pediatricians, colleagues, any diagnosis? Excellent. So this is neonatal chikungunya, the very characteristic, sign which we often refer to. And this is the type of pigmentation, which is called chick sign actually. Right? History of antenatal history, whether the mother suffered from chikungunya during pregnancy is very important. And then you do the IgG, IgM level, both in the baby as well as in the mother. So this is, chikungunya pigmentation. And, this was first reported in pediatric journal actually by Professor Nair. I met Professor Nair. He's a brilliant speaker from Kerala. So he reported first that hyperpigmentation over the baby's, philtrum and the adjoining lip is because of neonatal chikungunya. So what are the other types of chikungunya rash? Is pigmentation, maculopapular rash, vesicles, bullae, discommission, urticarial rash, purpuric, vasculitis and acrocyanosis. Let us see some pictures. So this is hyperpigmentation. Hyperpigmentation. This is linear erosions. These pictures are actually kindly contributed by Dr. Sahana M. Srinivas from Bangalore, one of my very good colleagues. Exfoliating rash. Coming to another condition, very itchy lesions persist for months together, papular urticaria. However, there is another condition which mimic papular urticaria, which is known as, papular acrodermatitis, or nowadays acrolocated papular syndrome, which is because of either hepatitis B as it was described earlier. So other viruses are also, may be responsible, like EB virus. It has an abrupt onset, monomorphic lesions, unlike papular urticaria, which is polymorphous lesions. So this is how this, Guillain-Barré cross-stitch syndrome looks like, as it is popularly known as. These are all monomorphic lesions. This is another entity. I told you that I shall introduce you to some of the entities which are newer entities, but you should be aware about these entities. This is known as unilateral asymmetrical exanthem or asymmetric perifexular exanthem. These are unilateral in distribution. They look like contact dermatitis, drug eruption, or sometimes scabies. So between 1 to 5 years is the age at onset. They are mildly pruritic or maybe totally asymptomatic. Parainfluenza virus, adenovirus or EB virus may be responsible. And it is typically unilateral. That's it. Oh, I have said 2 minutes, 16 seconds. Thank you very much for your patient hearing. This I contribute to Dr. Soma Panda, moderator, to utilize this time for the panel discussion. Yes. You could just tell your name and the city. I saw you in the last panel discussion, you were standing. Yeah.
My question is that you showed a slide of rickettsial...
It's working. Come close to the microphone.
Yeah, you showed a slide of... I'm Dr. Hemant Jain I'm a pediatrician from Delhi. You showed a slide of rickettsial hemorrhagic lesions. And that age group and the child is sick and having fever, how do we differentiate it from meningococcal?
Right.
And because that requires an IV and very immediate treatment. Doxycycline is an oral. Yeah, that's it. Thank you.
Very nice question from clinical point of view. In meningococcal infection, the lesions are hemorrhagic undoubtedly, but they are hemorrhagic lesions. They look like, henoxolin purpura, very small patches. Here you must have seen large patches with very crenated margin, right? That crenated margin is basically because of large area of necrosis. In meningococcal infections, there is hemorrhage, but you do not see much of necrosis. This crenated margin suggests that there is coagulopathy and there is necrosis, and there is a concept of skin blood supply, a triangular area of skin is supplied by one small capillaries. Another triangular area supplied by one small capillary. Suppose both the triangular areas are blocked, right, because of hypercoagulable state, then these triangular areas, they get sloughed off or become necrosed. As a result, the skinated margin develops. This is a very classical type of hemorrhagic appearance of rickettsial disease, which is not seen in meningococcal infection. In meningococcal infection, both presents, meningococcal and rickettsial disease presents with fever and hemorrhagic lesions and toxicities. But in, meningococcal infection, either you see hemorrhagic lesions just like Henoch-Schönlein purpura, or you see huge large necrosis, which is known as purpura fulminans. In fact, that is the commonest cause of infection-induced purpura fulminans, but not in small patches like rickettsial disease. Along with histories of arthritis. In meningococcal infection, you don't get any swollen joint or swollen limbs or arthritis. Is that okay, Dr. Jain? Or, okay, you're welcome.